Hi everyone, welcome back. In this video, I'm going to talk about the clinical symptoms of hyper and hypothyroidism. I have another video that's going to go through the causes. But let's get started. All right, but first we have to learn a little about the thyroid hormone itself. It's part of the HPA, which is the hypothalamus pituitary axis. So what happens here is that the hypothalamus is going to secrete TRH, which is thyrotropin releasing hormone. This is going to act on the anterior pituitary down here, and the anterior pituitary is going to release TSH, which is thyroid stimulating hormone, and this is going to act on the thyroid gland, and it's going to stimulate them to release the thyroid hormones, which are T4 and T3. And as you can see right here, most of the hormone that's secreted is T4. Now, this is a very tightly regulated process through negative feedback. What that means is that T4 and T3 are going to negatively feedback and inhibit the release of TSH from the anterior pituitary and TRH from the hypothalamus. So this is how we're going to keep our levels of T4 and T3 in check and prevent them from spiking too high. And if they're too low, then we're going to lose this negative feedback. And so you're going to have more of this upstream activity, and it's going to bring up the levels so that we can maintain them within normal range. Now let's talk about the actions of the thyroid hormone when they're circulating. So once they get to their target tissue, which is all cells in the body, so all cells in the body have essentially receptors for thyroid, then what's going to happen is that the T4, which was the predominant circulating form, is going to convert to T3, which is the active form, and then this T3 is going to bind its receptor inside of those cells, which is found in the nucleus, and then this is going to act like a transcription factor, and it's going to upregulate some gene expression. And these are going to lead to the effects of the thyroid hormone. So it's very important here to recognize that the target tissue for thyroid hormone is pretty much all cells. That means that thyroid hormone is important for regulating activity in pretty much most or all tissues inside the body. And that's why hypo and hyperthyroidism presents with so many different symptoms. So one of the main effects of thyroid is increasing the basal metabolic rate, and this is done by increasing the activity and expression of the sodium potassium ATPase. So this is a pretty high yield one to know. It also has tissue-specific effects, and essentially, as a general rule, you can think that the thyroid hormone is going to rev up the activity of those tissues. And finally, it has an important role in regulating and development of the musculoskeletal system, the nervous system, and the reproductive system. All right, so now we know about T3 and T4. Now let's talk about hyper and hypothyroidism, so thyroid diseases. So if we're right here in the middle, this is our euthyroid status. So that means that the T3 and the T4 levels are normal. So this is a euthyroid. This is where you want to be. If we move here more towards the red or warm side, that means that the T3 and the T4 levels are high, and this is known as hyperthyroidism because you have too much thyroid hormone, and the symptoms that are caused by this are known as thyrotoxicosis. So toxicity from too much thyroid. And if you go all the way to the end, so you have severely elevated T3 and T4, the most severe form of hyperthyroidism is something known as thyroid storm, which I'll talk about at the end. Now, if we come back over here on the left side, now we're getting cold, so the T3 and T4 levels are low, so this is hypothyroidism, and the most severe form of hypothyroidism is known as myxedema, coma, which again, I'll talk about at the end. All right, so for the rest of this video, we're going to talk about the symptoms of hyper and hypothyroidism and how it affects the different systems. So let's start with metabolism. So with hypothyroidism, the basal metabolic rate is down, so there's less use of ATP, and there's less generation of heat. So the problem here is going to be cold intolerance, and the problem is going to be weight gain because we're not using up energy and heat. And interestingly, hypothyroidism also leads to an increase in serum cholesterol because of the effects of thyroid on metabolism of cholesterol. On the other hand, with hyperthyroidism, now we have too much thyroid activity causing excess basal metabolic rate. Remember, this happens because of the increased expression of the sodium potassium ATPase. So now we're using up too much ATP and generating too much heat. So this is going to lead to heat intolerance and sweating. All the excess ATP use is going to lead to increased appetite to try to make up for it, but ultimately weight loss because we're continuing to rev up the system and use up ATP and energy. And again, as I mentioned earlier, the effects of thyroid is increased metabolism of cholesterol. So in hyperthyroid, we have decreased serum cholesterol. All right, now let's move on to the cardiovascular system. This is another one where it comes in with classic symptoms related to hyper and hypothyroidism. And the effect of the thyroid is that it primarily acts on the beta adrenergic receptors in the heart and increases their activity. So if we do not have enough thyroid, as in hypothyroidism, that's going to decrease everything. So just like what we saw with metabolism, everything is going to slow down with hypothyroid. So we're going to have bradycardia, or a slowing down of the heart rate, which is going to lead to a decrease in cardiac output. Then, of course, in hyperthyroid, we have the opposite. So everything is revved up again. This is a theme that we're going to see in every system. So here, this is going to lead to palpitations, tachycardia, which is a fast heart rate, and often can lead to arrhythmias. Very common one is AFib. And in fact, when someone comes in with new onset AFib, one of the things you want to check for is their thyroid levels to check for hyperthyroidism. Then finally, hyperthyroidism can also lead to systolic hypertension. That means that the systolic blood pressure is elevated, and that's because the systolic blood pressure not only takes into account the vascular tone, but is primarily affected with cardiac contractility that happens during systole. And because thyroid increases beta adrenergic action, which increases the levels of cardiac contractility, one of the high-yield features that's associated with hyperthyroidism is elevated systolic blood pressure. Okay, next, the GI system. So once again, same thing. The thyroid is going to rev up the organ. So when you have hypothyroidism, everything is slowing down. So we have decreased GI motility, which is going to lead to constipation. And as we mentioned earlier, there's also decreased appetite because we're using up less energy. However, despite the decreased appetite, we have weight gain. Hyperthyroidism is the complete opposite. So excess activity, everything is revved up. So increased GI motility, diarrhea, increased appetite, but weight loss due to the excessive basal metabolic rate. Okay, the neuropsychiatric system is also affected with the same premise. So with hypothyroidism, everything is slowing down. So the primary symptoms that the patient presents with are fatigue, lethargy, and depressed mood. And on physical exam, they would have delayed or slow reflexes. Hyperthyroidism would be the opposite. So everything is revved up. So this is a patient that presents with anxiety, insomnia, and restlessness. And on exam, they would have brisk or increased reflexes, as well as you could potentially notice a tremor on them. And again, as somebody who's presenting with new onset anxiety or tremors, one of the things you want to check for is their TSH and thyroid levels to assess for hyperthyroidism. Okay, let's talk about the musculoskeletal system. So in both hypo and hyper, we have proximal muscle weakness, but the key difference is that in hypothyroidism, the CK levels are elevated, whereas in hyperthyroidism, the CK levels are normal. Another important distinction is that in hypothyroidism, it can be associated with carpal tunnel syndrome, which is compression of the median nerve, and this is caused by edema that I'm going to talk about shortly. Whereas in hyperthyroidism, this is not so much associated with carpal tunnel syndrome, rather with osteoporosis, and that's because T3 actually stimulates osteoclasts, which are the bone cells that stimulate bone resorption. So this is going to lead to breakdown of bone and osteoporosis in hyperthyroidism. All right, so last system to talk about is derm. So we're going to talk about hair, skin, and nails. So in hypothyroidism, the skin is cool and dry. The hair and nails are brittle, and this can lead to excessive hair loss and alopecia. And myxedema, which is a generalized edema, is pretty common in primary hypothyroid diseases, and this causes a generalized edema. In hyperthyroidism, the skin is flushed, so it's going to be warm and moist. The hair is fine rather than brittle, and there's a classic nail finding associated, which is onycholysis, which is when the nail actually separates from the underlying nail bed. In this case, myxedema is not common in hyperthyroidism. That's primary, except in Graves' disease. It is a prominent feature of Graves' disease only. In this case, it only affects the anterior part of the lower legs, known as pretibial, as well as the eyes. On the next slide, I'm going to talk more about myxedema and help you understand it a little bit better. So myxedema is a non-pitting edema, and so it's a swelling in the interstitial space. And the pathophysiology is that it's due to excessive TSH. One of the effects of TSH is that it stimulates fibroblasts in connective tissue to increase deposition of glycosaminoglycans, these GAGs right here, and these then in turn attract water, and they're going to lead to swelling in the interstitial space and this non-pitting edema. So how does this relate to thyroid disease? Well, the causes, of course, are going to be primary hypothyroidism, because when you have a primary problem with a thyroid gland and you're not secreting enough T3 and T4, there's going to be a loss of negative feedback, which is then going to lead to stimulation of increased TSH. And this increased TSH is going to then follow this pathway, stimulating the fibroblasts and leading to increased deposition of GAG, swelling, and this myxedema right here. So this is why primary hypothyroidism causes myxedema. Now, if you had a primary hyperthyroidism, then your T3 and T4 would be elevated, and therefore your TSH would be low, so you would not expect myxedema in a primary hyperthyroidism, and that is in fact the case. The one exception is Graves' disease. So when you have primary hyperthyroidism due to Graves' disease, you actually do get a specific myxedema, And the reason for that is the pathophysiology of Graves' disease is that there is a TSH-like immunoglobulin that's stimulating TSH receptors everywhere. So that's the problem in Graves' disease. So this TSH-like immunoglobulin is going to stimulate the thyroid gland and lead to the release of more thyroid hormone, which is why Graves' patients have hyperthyroidism. But this immunoglobulin is also going to stimulate TSH receptors in these fibroblasts and lead to the rest of this pathway right here, increasing deposition of GAGs, attracting water, causing swelling. And this is exactly why Graves' hyperthyroidism is the one cause of primary hyperthyroidism that causes myxedema. All right, so let's quickly check back in now. We talked about symptoms of hyperthyroid or thyrotoxicosis, symptoms of hypothyroid. The only thing that's left is I want to do a quick mention comparing thyroid storm from myxedema coma. So let's wrap up the video talking about that next. All right, so now let's talk about these two life-threatening emergencies. Let's start with myxedema coma. This is severe hypothyroid. As you can tell by the name, it has myxedema in it, and the mental status is depressed, so that's why they call it coma. Symptoms are going to be exaggerated hypothyroidism, so we'll have hypothermia, decreased body temperature, and bradycardia, and decreased mental status, which, as I mentioned, where the term coma came from. And a couple of high-yield lab abnormalities. You're also going to have low sodium, hyponatremia, as well as low glucose in the serum, hypoglycemia. These are all the main key features of myxedema coma. The other end of the spectrum is thyroid storm. So again, you can tell from the name it has storm, so that means a lot of activity, a lot of action. So this is severe hyperthyroid. And this usually happens when there's a stressful event like surgery, infection, and trauma that leads to a burst of catecholamine release in someone who has underlying hyperthyroidism, essentially pushes them over the edge. And the symptoms here are, of course, going to be complete opposite of this top one right here. And the symptoms here are going to be associated with severe hyperthyroid. So we'll have hyperthermia, tachycardia, which is going to lead to arrhythmias potentially, and severe diarrhea. And the mental status here is going to be opposite. So it's going to have delirium, seizures, and agitation. All right, and here's a summary table comparing the symptoms of hyperthyroid with hypothyroidism, and here are the different organ systems. So you can pause the video here and review or save it for future use. Okay, that's it and that's all. I think the next best video to watch after this is the causes of hyper and hypothyroidism, which I've linked here. And if you guys enjoyed this video, please don't forget to like, comment, and share it with others, and also consider subscribing so you don't miss out on other content. But for now, thanks for watching, and I'll see you next time.